Hello, my name is Chloe Wright. I am consultant chest contouring and oncoplastic breast surgeon at North Manchester General Hospital, and we're a part of Manchester Foundation Trust. I'm presenting today on the topic of gynaecomastia, its assessment and investigation, its etiology and referral to secondary care. So to first give some background, gynaecomastia is enlargement of the male breast, and it's due to hyperplasia of the glandular tissue. It may present as a diffuse or discrete retroareolar mass that may be unilateral or bilateral. And this presentation is about gynaecomastia specifically and not eccentrically placed male breast lumps, which should be assessed and referred as necessary on a 2-week wait referral. And gynaecomastia is 5% of men, and the most prevalent age group is 50 to 69. It occurs secondary to alterations in the male estrogen to testosterone ratio, and it's important to distinguish it from pseudogynaecomastia. Pseudogynaecomastia being due to an excess of adipose tissue, and this requires no investigation or treatment. But the reason that assessment of gynaecomastia can cause concern and difficulty is the knowledge of the incidence of male breast cancer, which represents about 0.6% of all breast cancers and accounts for 350 cases per year in the UK. The causes of gynaecomastia can be considered into 5 categories, the first being physiological, and so this is a consequence of normal bodily functions. So it can occur in up to 90% of neonates and is due to placental estrogen transfer and resolves within a few weeks. It can occur in the pubertal period, affecting 60% of adolescent males, and it regresses in 90%. It can also occur in older age, affecting up to 65% of men, and it's due to a reduction in testosterone relative to estrogen. It can also occur as a result of medications that are prescribed, and the list of potential causes of medications is enormous. The main culprits are GnRH agonists, so used for treatment of prostate cancer, androgen receptor blocking drugs, androgen production inhibiting drugs, and all of these because they result in that relatively lower testosterone to estrogen ratio. Recreational drugs can also cause gynaecomastia, although the mechanism of action is poorly described. And it can result as a consequence of anabolic steroid use and alcohol excess. Potential pathological causes are adrenal or testicular tumours, and these account for less than 3% of all cases of gynaecomastia. It can also be secondary to systemic endocrine disorders, primary hypogonadism, secondary hypogonadism, prolactinoma, thyrotoxicosis, and androgen insensitivity syndrome. It can also occur due to systemic illness, to liver cirrhosis, renal failure, malnutrition and refeeding syndrome, and to obesity. And again, because of these resulting in that lower testosterone to estrogen ratio. The assessment of gynaecomastia in primary care is really well supported by guidance that is written by the Association of Breast Surgery and available on their website. A summary infographic is available at the gmcancer.org.uk website. The assessment, of course, starts with patient history, review of prescribed medications, questions about recreational drug use and current or previous alcohol consumption, ask about testicular lumps and any family history of breast cancer. Examination should include bilateral breasts and nodal areas, presence of any lumps, any nipple or skin changes, and if any gynaecomastia is unilateral or bilateral, and to offer testicular examination. The hard part can be defining who should not be investigated. Adolescents with physiological pubertal gynaecomastia can be reassured that it will regress in 90% and does not require investigation. Elderly men with age-related bilateral gynaecomastia can be reassured that it is a benign symptom related to aging. And in those for whom a clear drug-related cause is identified, to consider stopping or changing that causative drug. And if comorbidities mean that this can't be done, to reassure that gynaecomastia is a drug-related side effect, that it is not dangerous and does not require any further investigation or treatment. And in those with fatty pseudogynecomastia, for the discussions to be had that the gynecomastia is associated with excess weight and to address the issues of obesity on general health. Those for whom we recommend do have further investigations are if it is recent onset in lean men over the age of 20, if there is rapid enlargement, if there is persistent painful gynecomastia, or if it is persistent, that is greater than 2 years, or a massive adolescent gynecomastia. And we recommend that they are investigated with the blood tests as described here. If abnormalities are identified in any of those first 11, that the individual should then be referred to medical endocrinology. And if there is any elevation in beta-HCG or alpha-fetoprotein, they should be referred urgently to urology with an expectation that they would have a testicular ultrasound scan to assess for any occult testicular tumour. Those who require referral to a breast clinic on an urgent 2-week wait are where there is a clinical suspicion of malignancy. So if they are over 50 with the unilateral firm subareolar mass, if there is any nipple discharge, or if there is a unilateral ulceration of the nipple. To be referred on a non-urgent 2-week wait are those who have a unilateral lump with no obvious physiological or drug cause, or if there is an increased risk of breast cancer due to family history or a genetic condition such as Klinefelter's. For individuals who can be referred off the 2-week wait pathway, so that is if there is persistent, progressive or massive gynecomastia, it's important to manage a patient's expectations that surgery for gynecomastia is really only very rarely funded by the NHS, that it requires an individual effective use of resources application, and those will only be considered if the patient has large volume gynecomastia, they have completed puberty, are a non-smoker and have a BMI of less than 28, and also drug and medical causes must have been excluded. Hormonal treatment can be given for gynecomastia, and this is a tamoxifen or anastrozole. It's important to consider this treatment is off license and it's most effective for recent onset gynecomastia. It alleviates the mastalgia, but not always regression of the mass. And this is these medications that are very rarely prescribed for gynecomastia and is best placed to secondary care. So in summary, physiological gynecomastia and pseudogynecomastia are common and do not require investigating. We recommend using the ABS gynecomastia primary care management pathway to guide investigations. And those with symptoms or signs of breast cancer should be referred on an urgent 2-week wait referral pathway. There should be an awareness of the need for endocrinology or urology referral for men with gynecomastia and abnormal blood tests, and that gynecomastia surgery is only very rarely funded on the NHS. The full guidelines are available on the Association of Breast Surgery website, and the ABS gynecomastia algorithm is available at gmcancer.org.uk. And that's the end of the presentation, and thank you for your time.